recommendations. And as you will see, there probably actually are much more questions than answers to what is IMT and how could it be used for prevention in clinical practice. So first of all, I will remind that the common definition of this biomarker is necessary, and it has been provided by two consensus. The first, the Mannheim Consensus, 2004, updated in 2006, and more recently the American Society of Echocardiography published another consensus on IMT measurement. And the most important contribution of these meetings was to define what is IMT and what is plaque, because there were very wide acceptation of what it was, and as it was previously said, it could be measured on far wall of common carotid artery or near wall of this artery, or combination of the bifurcation and the origin of internal carotid artery. It could be single points or on 10 millimeters on the far wall. And so when you look at the literature, a lot of paper from Eric, from the study which started some 10 years ago, combine the measurement of the common carotid artery, the bifurcation, and the origin of carotid artery. The problem with this combination is first that you could not differentiate what is plaque and what is only thickening of the common carotid artery, and the genetics, for example, of plaque is different for plaque occurrence and for IMT thickening of the common carotid artery. So it's quite important to make this difference. So from this time, a lot of papers now use the far wall of the common carotid artery on a 10 millimeter length and with automatic edge detection, not manually. That was the Mannheim consensus. And next slide shows the ASC consensus. And here you see on the top what is IMT, the irregular thickening you can observe on the near and far wall of the common carotid artery on the longitudinal view, and the difference between the plaque, which is a focus thickening of the wall on the artery. So there is a large discussion, and you will see many discussions in the literature concerning what is better, IMT or plaque, and that's not really the question, because in the natural history of carotid atherosclerosis, it starts with intima-media thickening, and plaque comes after. So it's very important to pick up both information, IMT and plaque, and it's very important because IMT thickening has been proven to increase the occurrence of plaque atrophication in the population of asymptomatic people. Next slide. So what could be and what should be the IMT measurement? It should be reproducible, easy to perform, clinically relevant in routine examination, and associated to plaque detection. Repeated only in two situations: increased IMT and no plaque, or normal IMT and risk factor. And why should it be repeated only in these two situations? Because the standard deviation of the measurement cannot be compatible with the monitoring of individuals. For when you measure an IMT, there is no sense to to measure it 1 year or 2 years after, because the variation you can observe is not relevant if you take into account the variability of the measurement you can have onto repeated measures. So if there is a plaque, there is no sense to measure IMT for individuals, because definitely plaque is associated to an increased risk, which is more important than the one you can have with increased IMT. But if you have a normal IMT, you can have occurrence of plaque in a patient with risk factor. So it remains important to have a follow-up on this patient, not really to look at the variation of the IMT, but to look at the variation, at the occurrence of plaque, which will put him in a risk, in a higher risk category. That's the result of EVA study. EVA study was performed in a general population and with a follow-up of 2 and 4 years, 3 examinations, baseline 2 and 4 years. And this paper was published in 1996 and showed clearly that when the baseline value is classified in tertile, from the left to the right, in all the population, men and women, you see that the higher the IMT, the blue column, the higher the prevalence of plaque at 2 years. And you see the percent of occurrence of plaque on the last tertile, which is the red column, and it was in men and women in all the population. Other studies are looking at this prediction of this occurrence of plaque in a population with increased IMT found the same results. Next. So CCIMT predicts the occurrence of plaque. And that's only the follow-up at 4 years, which shows the same results. And we show that even if patients have plaque, it remains true that the occurrence of plaque is more important when you have a plaque as a baseline than with no plaque. Next slide. So now we're talking very briefly about reproducibility, because that's a real challenge. In this study, which is a box study that we perform within 250 centers in France, equipped with the same acquisition methodology, we found a very good intra-class correlation coefficient for the readings of the IMT, of the carotid IMT, but as you know, the most important for the reproducibility is not for the reading, which is normally quite good, but for the change for prospective study. And the results are much less, are not very good in the different studies.
So this is reproducibility within one subject, I mean one reader and one software, what is?
Yes, that's inter-observer reproducibility, but only for reading the same image. Okay, reading the same image. It's not two examination. Yeah,
it's
absolutely.
Software reproducibility.
Exactly.
And it's totally automated?
Yeah, it's
manual adjustment?
no, it's totally automated, but you have a quality index that tells you what to get the best, the largest number of points to detect.
So Alan Taylor reported the same thing. Is this accepted? All software that are out there have this kind of reproducibility or reproducibility?
Depends on the software.
But this is your software?
That's the software we use for the PARC study, yes. Yeah, absolutely. The PARC study, which is a French study, and the INCAMELA study in Latin America, on 12,000 people. So to monitor the IMT, it's quite different in epidemiological and interventional trials because the variability of the measurement is managed through very large numbers of patients and statistics allow to get some measurement. So how to reduce individual variability for single examination and for repeated ones. Next. So for the new measurement, we saw many papers on plaque characterization. David Spence will talk about plaque area and volume. And some paper recently insist on the possibility to measure the first echogenic layer that we can see on ultrasound images, which could represent the intima or an equivalent of intima. But that needs validation, and it will have the great advantage to discriminate what is remodeling and what is really atherosclerotic disease. Next.
And that's where your real issue of focal resolution comes in?
Because you want to measure just the
You
median,
can't measure the intima, what's it?
just the intima.
Yes.
Greater than the focal resolution, right?
But
Yeah.
No.
there is a 30 megahertz probe that's actually in visual sonics, which is currently used for animal studies.
Absolutely.
There have been actually some human work evaluating the radial artery intima.
Yeah.
But it still comes
Absolutely.
down to focal resolution.
Correct.
regardless.
So it's a
No, no.
30
It doesn't
megahertz
matter
probe.
how many megahertz,
Yeah,
how
well,
many gigahertz.
you both are
it
saying
all
the
comes
same
down to
thing.
focal
He's saying,
But higher the hertz, higher the resolution.
right, he's saying that you have to have a very high spatial resolution in order to detect the very thin layer.
No, that's the reason for which I said intima or its equivalent for the rest. That means that you could have an index within the measurement of intima media thickness, which is well correlated to atherosclerosis, but which is not the anatomy of intima.
I'm not disputing anything you said. I agree with everything. I just
No.
want more
Yeah,
to
I
understand
do
focal
know.
resolution.
We understand that
concept.
this is a
That's what I-
function of the spatial resolution or focal resolution that we want.
Yeah. Okay. So that's a simple and regular IMT measurement. It's done according to recommendation on 10 millimeter length, and that the plaque area thickness measurement. Next. So for plaque characterization, some software now can identify the low, mid, and high echogenic parts of the plaque, and you probably have seen some literature on the relationship between the event, the risk of cardiovascular event, and the echogenicity of the artery. So quantification of the percent of low, mid, or high echogenic part of the plaque could be interesting in the future to define or to have some information on the vulnerable plaque.
Is this available on any machines out there?
No, that's research.
I mean, I don't know if it's available on instrumentation, but certainly in software packages.
In software packages are available clinically to doctors? Has any of you worked with such a thing?
I have one which is not clinically available, but it's available for research.
And offer you plaque characterization and so on?
Okay, so just some index or characterization of the plaque. So that's just one slide which shows you the yellow line, the pink one, and the green one. And you can see that you can identify the first hyperechogenic part of the IMT, but at this time there is no clinical relevance associated to this measurement. So that's another advance in technology that could be interesting in the future that we are using for clinical trials, where you can have, next, Or you can have through the web, a web-based IMT measurement, where you define first the characteristic of your patients. Next. Then you upload your image and on both carotid 3. Next. You calibrate directly your measurement on the web. Next. And you can get IMT measurement and plaque area. That's particularly interesting. Next, for the quality index that you can harmonize through many centers. Previous one, yeah. You can have a secure data storage and a real-time evaluation of center activity with a highly cost and time effective. So we'll organize at the ESC, which is the European Stroke Conference, in May 2011, a symposium on IMT in clinical practice. Is it the past or the future? Thank you for your attention.
Okay, great. Thank you very much.
I think we're going to go next with Dr. Spence. I'd like the 4 speakers to spend maybe 10 to 12 minutes each so that we can finish on time. So Dr. Spence.
Some of the data that were presented, we don't need to discuss about those basics, and let's go straight to.
Dr. Spence.
The slides are coming up. Feel free to use the time.
Yeah. So what I'm not saying is that people shouldn't measure intermediate thickness. What I'm saying is that if there's plaque, you should measure it. And just defining the presence or absence of plaque isn't enough. And that looks like I can change it here. So in our lab, we use ultrasound and stroke prevention in a number of ways. Plaque measurement for patient management, genetic research, and transplant development for detecting microemboli. I think it's really important to understand and distinguish the ultrasound phenotypes of atherosclerosis and to understand that they are biologically and genetically distinct. And within intermediate thickness, it's very important to distinguish IMT measurements in the absence of plaque, deliberately excluding plaque, and IMT measurements that include plaque thickness. They're different animals. So here's the Mannheim consensus in the distal far wall where there's no plaque. That's a different thing than plaque, than IMT measurements that include plaque. I'll show you the Tromso data about that. Stenosis is probably not the consequence of plaque progression, it's the consequence of plaque rupture and thrombosis. So these are different things. And if you look at the biology, by looking at coronary risk factors, the proportion of explained variance, the R squared, is 0.15 or 0.17 for IMT, 0.52 for plaque area or plaque volume, and only 0.13 for stenosis. They are biologically different. The key issue that hasn't yet been discussed is measuring change over time. And we published in 1997 evidence that plaques go along the artery 2.4 times faster than they thicken. So you can measure change in plaque area or volume much more easily than changes in thickness. Another issue is that if you're trying to measure burden of atherosclerosis, here are 2 examples from one of Ralph Hegele's studies in which we measured IMT. These 2 individuals had a very similar IMT. The plaque area, though, is double in this case, and the plaque volume is 10 times in this case. So if you want to measure burden of atherosclerosis, and if there is plaque present, it should be measured. And I'm going to, in the interest of time, skip through this, but we've published a fair bit about this. Now, there's increasing evidence that plaque is more closely related to coronary disease. Carotid plaque and coronary disease are more closely related. And the presence of plaque, and even better, the burden of plaque, is more strongly predictive of coronary events than IMT. Here's our paper in 2002 showing that after adjusting for everything, more than a Framingham risk factor, patients in the top quartile had a 5-year risk of around, what's that, 15% in the top quartile. And the ones in the top quartile had 3.4 times higher risk than those in the lowest quartile. And in the first year of observation, we saw progression of plaque in half the cases, regression in a quarter, and we found that after adjusting for everything, patients with progression had twice the risk of those with stable plaque or regression. So this meant that treating our patients according to guidelines was failing in half the patients. So
The risk here is a stroke or all cardiovascular?
stroke, death, or myocardial infarction in 5 years. And I disagree with Howard. I don't think you can measure change in IMT within an individual because of the spatial resolution area. The annual change is about half the spatial resolution. The annual change in plaque area is 11 millimeters squared, which you can easily measure with a resolution of 0.3 millimeters. And as I'll show you, the change in plaque volume or vessel wall volume is much more. Now, we showed in 2005 that patients, among patients with carotid stenosis but no symptoms, 10% had microemboli detected on transcranial Doppler. So you have, and then when you hear the microembolus, the ones with microemboli had a very high risk, a 1-year risk of stroke of 15.6%. The ones without microemboli could not possibly benefit from endarterectomy or stenting. But we began treating in our clinic, we began treating plaque instead of treating risk factors. And the result of that was that microemboli went away. So before 2003, it was 12.6% of patients with microemboli. After 2003, it was 3.7%. The rate of plaque progression before 2003 was 70 millimeters squared and dropped to 20 millimeters
You
squared.
mentioned you treated them aggressive. What did you target? More aggressive LDL?
I don't target the LDL, I target the plaque progression.
But
If
how?
they're progressing with everything, Mediterranean diet, smoking cessation, exercise, highest dose tolerable of statin, adding ezetimibe, adding niacin, adding fibrate, whatever the hell it takes.
And the total
Yeah.
population, 346?
In this, no, it was 438 coming up in this group. Now, the average age of our clinic population was aging quickly, went from 50 to 65 in 5 years because I gave away my hypertension clinic and opened a stroke prevention clinic, and stroke patients are older. I showed you before the rate of plaque progression increases with age. So as our clinic population was aging, we should have seen faster and faster plaque progression year by year. And that was the case until 2003 when we changed the paradigm to treating arteries. So plaque change from year to year was going up, and then it crashed. And since 2005, we now see regression of plaque on average. And you might say, well, it's just because you're treating everybody with statins, but it's not the case. If you look here, before 2003, half the patients with progression, a quarter with regression. Now it's flipped, half with regression. As you would expect, in 1998, the ones with progression had higher LDL cholesterol than the ones with regression, millimoles per liter. But in 2007, the ones with progression had higher LDLs. The ones with progression had lower LDLs. How could this be? Well, it's because we were trying harder and harder to stop the progression. What happened to events? We still see that patients with microemboli have significantly higher risk of events. But if you look before and after this change from treating risk factors to treating arteries, the 2-year risk of stroke went from 8.8% to 1%. The 2-year risk of myocardial infarction went from 7.6% to 1%. So not only the microemboli went away, but the events went away. So my mantra here is that trying to treat arteries without measuring plaque would be like treating hypertension without measuring blood pressure. Here's an example. It happens to be my right internal carotid artery. I went off my rosuvastatin last fall or the fall before this because of myalgias. And I was concerned that my plaque area had gone from 20 millimeters to 28 millimeters, and there was this soft plaque here. It just happened to be a demonstration for a visitor, right? So I went back on my statin, just 5 milligrams of rosuvastatin, and between April 15th and July 23rd, the plaque went from 28 to 19 millimeters squared, and most of the soft plaque is gone. Plaque changes much faster than doctors think it does. Here is a receiver-operator curve showing that adding plaque area significantly improved the prediction compared to various risk scores like Euro score and Propane. This is the paper from Renu Vermani's group in ATBB in 2009, reporting that from a pathologist's point of view, IMT is something different from atherosclerosis. Plaque is atherosclerosis. In the Tromsø study in 2007, stroke, makes the point that I started out with, that IMT in the absence of plaque is a different thing than IMT where plaque is included. And in this study, it was a population-based study of 6,000 odd people. When the bulk IMT, including plaque, was excluded from the analysis, IMT did not predict MI. On the other hand, IMT, including the bulk with plaque, was significantly predictive, as was plaque area, total plaque area. Now, where we're heading is 3D, but before that, there's this issue of genetics. There was a question over here about what is the biology of these people who have a lot of plaque progressing quickly. If you do multiple regression with traditional risk factors, the R-squared is 0.52. We just published in Circulation Cardiovascular Genetics evidence that using extremes of the distribution, the residual score in the regression models, the quantitative trait, you can reduce the sample size required for genome-wide association markedly. So if you take 250 people with way more plaque than you would expect, and 250 with no plaque despite risk factors, you can get the same power as using 2,000 patients from a case control. And I don't have time to go into this, but plaque unexplained progression is even more powerful because it eliminates age from the consideration. This review is probably the best one to look at for genetic differences between IMT and plaque. Now, when we find new therapeutic targets using these genetic tools, we're going to need to be able to assess the effects of them. So here's Michiel Bott's estimate of the sample sizes required for IMT to show effects of therapy, something like, several hundred patients followed for 2 years. And we asked the question in 2005, using plaque volume measurements, in how small a sample and in how short a time can we detect effects of therapy? Here's the first plaque volume measurement that I know. This was my right carotid artery in 1994, so the plaque was a bit smaller then. Here is an example of some of the huge plaques in these patients in the study they all had carotid stenosis. They're huge plaques, and they changed much more than you would expect. So this is 17 patients on placebo 17 on atorvastatin versus 21 on placebo. In 3 months, progression on placebo versus regression on atorvastatin. There's the rate of progression in the two groups. The sample size is required to show effects of therapy. If you can wait 6 months, using these data, you need something like 50 patients per group followed 6 months, even if your treatment is only 10% as powerful as the difference between high-dose atorvastatin and placebo. Now, vessel wall volume is really 3D IMT that includes plaque. And the reason I recommend using that instead of just a thickness measurement, if you want to look at a change over time, is that this quantity changes very quickly and is easily measured. And this is the effect of atorvastatin, the same images, significant differences in 3 months and 20 patients per group. This is a dietary study from Israel where just diet, never mind statins, patients randomized to several different diets, Atkins versus American Heart versus Mediterranean. Patients with the big blood pressure reductions of 22 millimeters mercury had regression of plaque by 110 millimeters cubed of the vessel wall volume. So vessel wall volume, which is really 3D IMT, is going to be a lot easier to measure and changes much more quickly.
Is it measurable? Can we do it with existing devices?
You can use, you can plug in a machine that captures horizontal or cross-sectional slices and stacks them up to make a volume. And you can plug that in.
But the arteries is not a straight.
No, but you're doing cross-sections and stacking them up.
Okay, there's an external motor that you connect and you
Yeah.
put around 360 degrees, so it collects all the individual images and then it puts them together. So it's not really 3D, you're collecting many 2D images and putting them together.
Okay, so it's a software reconstruction.
Yeah.
Hardware
Yes.
and software.
Yeah.
Post-acquisition.
Now, apart from plaque volume and vessel wall volume, the other things we're headed for ulceration and the quantification of the degree of plaque roughness.
What do you mean roughness? How is that?
Okay, so it's using techniques from topographical mapping. So these red spots are ulcers, but you can assign a score to that artery of how much roughness. That I can send you the papers if you want to see them. Now, the question of what percentage of patients have measurable plaque, I published in 2006. These are not healthy people off the street. These are patients in a prevention clinic. So, age 35 to 45, we found measurable plaque, and I have to say, we defined it as 1 millimeter, a focal 1 millimeter thickness, not 1.5. If it was 50% thicker than the surrounding area, it was a plaque. So 75% of patients had measurable plaque at that age group. By the time you get above age 75, it's 100%. And by the way, during the earlier discussion, I got into my database and asked the question, what percentage of people over age 75 have stenosis?
So what is the definition here, please?
It's the focal thickening of greater than 1 millimeter. Now, and what I was just saying was that I got into my database when you were asking the question about how many people over age 75 have stenosis. And in my patient population, the data on 843 people over age 75 was that 30% of them have 50% or greater stenosis on one side, and 15% have a 70% stenosis or greater on one side.
That's great for screening. That warrants a screening. But if there are 99%, then what do you need to screen for?
Yeah, plaque, yeah.
That's a
Where's the
very
other
high
one?
prevalence of plaque in the 35 to 45.
Yes.
Is this a
Prevention.
population enriched with risk factors?
No, it's a prevention clinic.
Yeah, so it's not a general.
Yeah.
There's not
Off the
mall, there's not mall,
No.
shopping malls
No.
population, but
This is a referral box.
Yeah, but still, it's 99% of the population has a positive test. So doing an IMT can't possibly be cost effective if the answer is they have disease already. Right, it's just, you don't need to do the test if the answer is yes.
Well, we have to keep that in mind. We have a huge selection bias.
Yeah.
He's a
How big?
famous
No, no, how big
neurologist,
is the
and people
selection
send people, you know,
Yeah.
look at
Maybe one
it.
risk
That's
factor.
different. They're all probably have some other risk factors. This is not general population. We're gonna look to, next presentation when HRP trial is being presented. That's the general population, and we'll see the percentage over there. Okay, sorry, we're running out of time.
SICO invented plaque measurement in our lab in 1990.
You know, this, by the way, this data is not very different to our own data because where we did.
Yeah, but those again are referred to us.
Right, but this is also prevention clinic.
Right.
This is
So-
not people from the street.
That's exactly the same.
So it's
Yeah.
not prevalence.
In the Tromso study, the amount of plaque from healthy people in the population was about 1/3
Oh, that's-
compared to our patients.
That makes sense.
Yeah, that would be much better.
Okay,
So next presentation.
Dr. Nakri from your
Why
seat.
don't you put this-
Are you, is that you? Do we have some lights here? Is it in shape too?
Yes.
Yes, it's a nice shape too.
Okay, so I'm going to present data from some of the more recently conducted studies because I thought that we were kind of discussing particularly these ones. I'm going to be the focus, but here and there I'm also going to touch upon some of the points that we've been discussing. And again, you know, this is, I think I'm going to try and keep it confined so that it helps us revise our own risk stratification scheme that really we are here to discuss. So the first one is the reevaluation of ERIC data incorporating plaque with IMT and seeing how that in combination with the traditional risk factor impacts evaluation of cardiovascular risk. As you know, this was conducted in 45 to less than 65-year-old people. This is the time period that the patients were recruited. So they measured the traditional risk factors as well as IMT and plaque. They ended up with 13,145 patients who were then followed up until 15 years from the time of enrollment. About 1,000 men and about roughly over 500 women, and this is the endpoint that were looked at. Majority of them were MI or coronary death, but there were some softer endpoints as well. I'm just going to talk a little bit about the way they analyzed IMT, because that affects as to how we interpret their data. So they had trained readers. They evaluated the IMT of the far wall only, not the near wall of all three segments, the CC at the above and the ICA at anterior and posterior angles on both sides. And then this is how they adjudicated plaque. And again, if we are going to define our definition of plaque, we may want to look at how these people looked at plaque, although remember this was conducted in 1989 and we have far better ways of assessing plaque now. So they called a plaque if two of the three criteria were met. Abnormal wall thickness defined as CIMT of 1.5 millimeter or more with abnormal shape, i.e. protrusion into the lumen. With or without loss of alignment with adjacent arterial wall boundary or abnormal wall texture that is brighter echoes than adjacent boundaries. And I think you are all familiar with this. They found overall that using IMT and plaque in combination with the traditional risk factor improved the area under the curve overall compared to the risk factor alone, although the improvement was subtle, but nevertheless an improvement was seen particularly in women. But this is the point that we were discussing earlier as to whether there is a need to image patients who have pending risk of less than 5%. And this is the data from this ERIC evaluation. So in men, they found that about 8% were reclassified from a very low risk to a higher risk, but the higher risk that they went up to was really the 5 to 10. None of them, as you saw in the table earlier, went to a very high or to 10 to 20 or more than 20% risk. Most of the reclassification by imaging occurred in the 5 to 10 and the 10 to 20% group range. And most of these patients, there were more patients downgraded than upgraded. As you can see, about 35 to 38% patients had revision of their risk score in men, and this is the data in women, kind of similar, but 5% were upgraded from the very low risk category, and about 40% were reclassified between 5 to 20% risk categories. This is just something that this group came up with, which can be incorporated on top of the framing of risk model. There is a website that you can go to, and they will ask you to punch in all the routine numbers that you punch in for framing of risk, and then after that they ask you to do the carotid wall thickness, which is the mean wall thickness for male and female, and then they ask you if there is carotid plaque, yes and no, and then it gives you a calculated risk adjusting for this IMT and the plaque value based on their evaluation of ERIC data. This is another study where I participated, so I'm kind of very familiar with their protocol. This study really took patients, which SHAPE is really after, which is patients age 45 and above who have low framing of risk, and their definition of low framing of risk was 10% or less, who had not developed known coronary artery disease, and the subjects were randomized to rosuvastatin versus placebo. So obviously, if they had a placebo arm, and this study was conducted recently, they had to have low risk framing of subjects. They did a useful thing, which is they tried to choose a winner, which is to take these subjects, image them, and then if they had subclinical atherosclerosis, to enroll them. And subclinical atherosclerosis was defined as at least one area of maximum IMT of 1.2 millimeter in either of the carotid segments, but the plaque had to be less than 3.5 millimeter. This is the age group they ended up with. The LDL cholesterol had to be between this range depending on your risk factors. If you had higher risk factors, you had to be here. One risk factor, you could be here. Triglycerides, and then this is the CIMT definition for purpose of enrollment. As expected, rosuvastatin significantly lowered LDL cholesterol, triglycerides compared to placebo. And this is their primary endpoint, which is the change in maximum CIMT of all segments. And this is near wall, far wall of CCA, bulb, internal, on multiple angles on both sides. And you can see that in the placebo group, there is a progression, and this is the standard deviation. Whereas in the rosuvastatin group, there is no progression. They couldn't really say there is regression, but they found that there was no progression in the primary endpoint. But when they looked at their secondary endpoints, which was to look at individual segments, which is the ICA, the CCA, and the bulb separately, they found that they were able to see some regression in the maximum IMT of the CCA on rosuvastatin in this asymptomatic population who had atherosclerosis identified.
Could I ask you, could you go back to 2 slides?
Yes.
The progression that you showed, that's a group, one more. This is mean. So if they were to analyze the same individuals, for example, me, at baseline versus a year later,
Right.
and just calculate the delta. So this analysis, rather than getting mean, if you calculate the delta, would they be able to do this kind of?
In a population, yes.
No, individual. I mean, you just get like delta.
Right. Well, can I just come to that point in a second, and we can discuss this because of that correspondence I had. And anyway, so this is the rosuvastatin group. You can see regression if you just measure the maximum IMT of the CCA, and you saw progression when you took the placebo group in all the different beds of the CCA, of the carotid itself. And this is the actual delta that they observed. This is the placebo, increased by 0.01 millimeter, which I think you could say is within the resolution of the ultrasound, if you assume that the resolution is, well, 0.1 would be the resolution, right?
Yeah, but you can't measure them with
Right.
ultrasound.
In a group, you can.
Well, that's the point here, is that if you had me doing 2 measurements, would you be able, within a year, would you be able to see 10 micron or 13 micron changes? Well, Howard says it doesn't have...
It has nothing to do with focal resolution. What it has to do with
Okay, I have to
is
show
the
this.
standard error around
Okay.
the measure. That's what Dr. Tubal had presented, and that's
Okay, this is-
exactly right.
This is something
So if
interesting.
your variation is greater than what you're able to measure, then you can. And that's where group means has to come in.
Your IMC has to be more than your resolution.
So it depends, it has nothing to do with resolution. So it has to do with reproducibility. It has to do with your ability to reproducibly image. That's what it comes down to.
Reproducibility has 2 major components. One
That's
is
right.
the operator is going to measure the...
And that's
that
the
is
major
the
one.
hugest factor.
You got it. You got it. If you don't have a reproducible way to measure in individuals, you will not be able to measure change.
Because the operator can move the hand just like
You got it.
5 degrees and you get 2 different readings.
You got
I
it.
mean, I can see it right in front
Now
of
you're
me.
understanding. Exactly.
All right.
Exactly.
So this is the information that I got from GE. This is their 510K application that they filed for IMT 2 years ago. And their resolution means the ability of the ultrasound system to be able to separate out 2 points in a phantom. So if you were to put 2.77 microns apart in a phantom, the machine would show it to you as 2 distinct dots if you used a 10 megahertz transducer. So that's what that is, I believe. But then they're saying that this only applies if IMT is larger than the pulse itself, which it is, and this is the pulse wavelength. Now this resolution they're saying is only correct if you were to make 1 measurement. But normally we make hundreds of measurements of hundreds of points, and so because of that, the precision actually becomes square root upon number of points. So for a 10 megahertz probe, which has a wavelength of 154 microns, for 100 points you should achieve an accuracy of 15 microns, is what
Okay,
they're
well,
saying.
let's just stop right here. This man has spent 50 years of his life on ultrasound probes, correct? Is that possible? Can we get a 15 micron accuracy on these? You do that in
On a
mice.
100?
We measure mouse carotid IMT. But can we do that in human?
Well, I think what she's getting at is that you have depending on how you digitize the image, and most of the time we digitize it, so you have pixels. And so your resolution on each line is whatever the pixel is, but if you image a lot of them,
Yes.
then you can average out where the lines are, because if you have there's I guess a statistical chance if you've got a real thickness that's between 2 pixels that you're going to hit the high one versus the low one. And so if you do a lot of these, the statistics tend to average it out, and that's where this 1 over the square root of
But that's a numerical
numbers.
averaging. That's a numerical
That
averaging.
is theoretical. This is the theoretical formula, and nobody has actually tested this, but and that's the rationale that you can actually put out. So imagine if you use a 55 megahertz transducer, which is what visual sonics can do, and I'll show you a picture of that. Your resolution will be higher.
Well, the chairman said we were out of time.
Okay, well, can I? Okay, let me just show you a couple of, I'll really be very selective here. So this is the study that was the Arbiter 6 study. And I personally, I'm sorry to say, but it's very hard for me to digest this data. So the absolute value in this data, as you know, this was a randomization of high-risk people who were already on maximum statin therapy, whose LDL was below 100, who were randomized to niacin 2000 milligram versus ezetimibe 10 milligram. And they found that they had paused the study earlier because they found a significant difference in primary endpoint, which is carotid progressed in the Zetia arm and regressed in the niacin arm, and it came out in the New England Journal of Medicine. Now, the machine they used is the Sonocyte machine, and they have not described their software robustness of edge detection. And using that particular software, they're getting an inter-test, inter-subject, inter-observer variability, which is like 0.0001.
I think this is the next
This is
Nobel Prize. They
Right.
get that
Right.
kind of resolution.
This is their data on IMT, and okay, this is one slide I would like to share, which is the data from this CAC versus IMT in the elderly, because we talked about this point whether we should be screening over 70-year-olds. And they found that at 5 years they had 127 events, and the hazard ratio for fourth versus first quartile for CAC was 2.1, and for 2.3 for IMT. So comparable prediction of cardiovascular risk in this elderly population. And this, if you look at MI, and this is the stroke rate is better predicted by IMT compared to CAC. Otherwise, the prediction of cardiovascular deaths was comparable. So you do predict more strokes. I think somebody is going to touch upon this study. I'm not going to go here. This is our own little data, and I just wanted to point out. So we studied our own population, 136 asymptomatic prevention clinic patients who we scanned by both comprehensive IMT, plaque assessment, and coronary calcium score. PK and Dan helped me with this project. And we ended up with this kind of configuration, 103 low-risk patients, framing number of less than 10. And we had a very small number of intermediate and high-risk patients. But this is what I wanted to show you, that even in this low-risk group, 41% have CAC of more than 0. Okay, and then as you look at IMT, 50% have IMT of more than or equal to 75th centile. If you looked at plaque, 59% had plaque, which we defined as equal to or more than 1.5 millimeter. So in other words, this atherosclerosis is fairly prevalent, and obviously the prevalence increased in the 33 subjects who had intermediate to high-risk Framingham score. 70% of them had CAC of more than 0, and 87% of them had increased IMT and plaque combined. And we did reclassify them into higher or lower risk. So you can see 103 Framingham adjudicated low risk were changed by IMT scoring, so 23 now went to the 10 to 20% range. Similarly by CAC, 14 went to the 10 to 20% range in the very low risk group here. And let me just skip through these. And this is data very similar to our study. However, they actually followed their patients for events, which we haven't done, and shown that if you had abnormal IMT, then you had a higher event rate, and if you had plaque in addition, your event rate was even higher, and this is all low-risk people. So you have 13 and 15% event rate in this population with a 5-year follow-up. I think I'm going to stop here.
You're going to show us the high megahertz.
Yes, there's that picture gone, yes. So I just went to internet and I downloaded this picture.
That's visual sonic.
The visual sonic, where did it go?
Well, it's now Sonosite.
The visual sonics has not been acquired by Sonosite, that is correct.
We use the mouse.
I think it's in
For-
that
for
little,
your
it's in that little
information,
thing I gave you.
Dr. Hartley is the inventor of that technology. It's basically from his.
But nevertheless, what this technology is able to do is it shows you intima, the boundaries of the intima. The reason we measure intima media is because the ultrasound does not or did not have the resolution to separate out the intima, but now apparently with this, you can. The problem is the penetration. You really cannot do this on thick necks because the resolution of a high 30 megahertz is really not that deep.
Is this the slide?
No.
Well, we're going to move on.
I'll get it out.
Okay, we can come back to this after Henrik's presentation. Henrik, sorry, we couldn't show you everything that was shown here on the screen. Try to be on the same page. Now we're moving to GoToMeeting. Henrik, are you still there?
I'm still here.
Good. Now, David, could you help me find Dr. Silicon's presentation? Henrik, can you see your presentation on the screen, or we need to move to your change of presenter?
No, as long as you open it, I can see it. I see it on the other presentation. You just need to open mine.
Okay.
So while you're doing that, I would like to begin with apologizing for not being physically present. Yesterday, my wife and mine 2 weeks vacation started, and with my normal schedule, it's advisable to be home or to be with my wife at the vacation that going on.
Henrik, I'm going to make you the presenter here, so you just
Yeah, okay.
and then so you can navigate the slides at your pace.
The only thing is that I can't see it now.
Well, we can see,
Okay, I got it now, okay.
we can see your screen. Don't show us your private things.
Okay, so you can see my screen. Okay, so do you see a slide now? Or,
Yes.
It's from,
Now we see your bank account there.
yeah, okay. So you see this colorful slide here, which I thought that maybe the previous presenter would have shown, but I believe this just shows from the Eric study that for whatever IMT quartile, the lowest intermediate or the highest, adding plaque increases the risk almost by a factor of 2. So you all see that, right?
Yes, we can see the screen now.
Okay, so I will then immediately go on to the high-risk plaque study, just stating that from previous studies, I think it appears that the presence of carotid plaque in future events somewhat stronger than IMT, maybe not a lot, but a little. And the main point is that apart from what Dr. Spence showed you, that all the large epidemiological studies that have included plaque has done this by using two-dimensional ultrasound without any quantification. So it was plaque, yes or no. So the high-risk plaque study, the bioimaging study there, will be testing whether or not 3D ultrasound will be superior when we also quantify the size and maybe also texture of plaque. So, one back. So the purpose of the high-risk plaque is if we, by investigating helping people by non-invasive imaging methods, can we better predict those who suffer atherosclerotic complications. And we do that screening 6,100 asymptomatic Americans, where we aim at those at really intermediate Framingham risk. Now, all these people have had carotid ultrasound performed where we look for IMT and plaque. Everybody has had a coronary calcium score. Everybody has aortic diameter measured, ankle brachial index, plus a whole range of regular tests, blood pressure, ECG, and a big battery of blood tests. Among those with positive imaging findings, we initially performed coronary CT angio or MR carotid angio. All these cases will be followed for 3 years. And for comparison, we have another cohort of 1,300 where we only did Framingham risk scoring without any imaging. Primary endpoints, death, MI, and stroke. Screening started scan and record that. And the last 3,800 cases, we had the Philips VO135, which is an automated 3D transducer available, so we recorded that as well for this study. And then, of course, all cases had a color Doppler done to quantify if there was stenosis using the well-established criteria. And then we did aortic diameter as well.
Was the aortic diameter also 3D?
No, that was just a 2D cross-sectional image. So we saw all kinds of plaques. I'm showing you 2 examples here. This is supposed to be the video. Let's see if it works. So this is the sweep. So now we move the transducer up along the neck, and you see the plaque developing in the common and the internal carotid. I'll play it once more. So now we're back to the basic common. We're moving up to see the plaque developing here. Now we have the bifurcation. The plaque continues a little bit into the internal and stops. So this is the movie we use for plaque quantification.
Was this EKG gated down there?
Yeah, everything is EKG gated.
Okay.
So for the analysis, we used Philips software. Everything was done on 2 Philips machines. And Philips has this quantification tool they've had for a number of years called QLab. And there is a commercially available IMT tool, which is on the left side here, and you see actually the measurements here. On the right side is what's called unreleased research code still in development. And I can guarantee it's still in development because we still have some issues with total calculations. But anyway, what you see here is how we delineate the lumen, the media adventitia border, and how then the software can by itself more or less find the border of the plaque and outline it for us. So this first result slide, or let's say intermediate result slide, shows the distribution of our findings of IMT in the first 4,000 cases we measured. Now, in distinction from some of the other speakers' IMT measurement, we did one IMT on each side. So not multiple IMTs, but we did one IMT, the distal 10 millimeters of the CCA, and the movie. So we used then the ECD-gated movie, and then measured at least 5 values, and if they were very different, we would measure more, so we had a good bunch of values to average. And I guess this normal distribution is very much like what you would find in the population age between 55 and 80. Now for the plaque quantification, this is supposed to show how the transducer is moved from the left to the right, and as we as we move, you see there's plaque in between. So for each of these individual frames we can then outline the plaque as you see in the right here. So we get then the plaque outline, and once we have the plaque outline, we can calculate area or whatever we want, residual lumen, etc. Now, bear in mind that this is what we call the 2D sweep. So this is manually moved, which means that we don't have control absolutely of the speed which we move with, so we cannot calculate a true volume. So this is supposed to show a move with the outlines, but I know the movie is missing, so you can't tell what's flying or whatever. You probably won't see if it works on my computer. Do you see moving?
Yes, but since it's a bandwidth issue, we're seeing it choppy.
Okay. Okay, I'll just skip that. Okay, so here's an example of how the QLab plaque software shows the outline of the lumen internet border and the media adventitia border. So on the right side here, we get a number of values, wall area. If there was a stenosis, that would have been here, etc. And here's the case with the plaque. And again, you see the lumen intimat border and the media
So this can be used for plaque characterization.
Plaque characterization and plaque quantification. So if you look at values of plaque presence reported in the big studies, the Eric, Northern Manhattan, the Finnish study, the Berlin study, etc., the average is somewhere between 25 and 41%, and we found 80%. Now, there may be some differences in age groups here. We're probably on the older group, but still, I think that the main difference is that we have a more 3D-like approach using the cross-sectional sweep from the classical to the medical. So we would probably, for that reason alone, find more than using the 2D approach, which was done